So without further ado, I'd really love to welcome our keynote speaker. We're so fortunate to have a former colleague of mine from Washington, D.C., Shawn Cavanaugh. Yep.
Is it on?
Yep. All right. So Shawn and I actually had a good fortune of working together inside the federal government at the Center for Medicare and Medicaid Services. And I was employee number 5 at the Center for Medicare and Medicaid Innovation, the center that is creating new payment models, ACOs and bundled payments, and all of the things that make all of our lives so hectic to try to keep up with the reimbursement landscape. And Shawn was fortunate enough, and we were fortunate enough to hire him. He started his career on Capitol Hill in Washington, D.C., went on to New York and worked for the Hospital Fund, and returned to D.C. and started working at CMMI and was most recently the head of Medicare. So the largest insurance company in the U.S.
World.
Well, yeah, fair. Whoa. Shawn was at the helm of. And so we're really fortunate to have someone with this level of expertise, exposure, insight into the reimbursement landscape, what it is, where it's going, and what's happened over the past several years. So Shawn, just recap for us, we're in the backyard of Silicon Valley, startup land, all these cool things going on. What was it like at CMMI?
I can say this now that I'm out of the government. It was complete chaos, particularly at the beginning. As Kelsey indicated, the Innovation Center was created by the Affordable Care Act. So when we arrived, it was just being started. Kelsey, you were the 5th or whatever. I was the 19th employee. There's now like 450. But at the beginning, there was a handful of us, and most of us had come from outside of government, which was the purpose. It was purposeful. We want innovations, bring people from the private sector in. The problem is we didn't know how to do anything within government, which is government, as you can imagine, operates very differently. So, I needed pens. Where the hell do you get a pen? Things like that. So it was chaotic, but over time, it was also exciting. Because as you said, I think it's an interesting contrast to the current administration. The current administration has a healthcare policy, right? They're very clearly in there trying to get rid of the Affordable Care Act, which is a negative policy. They're against something. We had the good fortune of having a president, secretary, Congress that was for something. So even though we were running around, didn't always know what we were doing, we knew what we were trying to do. And we had purpose, and it was really a lot of fun and exciting.
Yeah, so let's just kind of air this out right now. So what do you think the future of the reimbursement landscape is? Do you think that ACOs and bundled payments and all of the things that are actually creating collaboration opportunities amongst all of us in this room, that are giving us new channels to pay for things and explore new care models, are those going to stick around, or what's, you live 9 blocks or 10 blocks from the Capitol. What's your pulse on it these days?
It's an excellent question. I get that question wherever I go. My strong sense is, so you have, in Washington, there's often very much focus on the president, particularly when the president, as our current one is such a character. But what people forget is Congress yields a tremendous amount of power in the federal government. And in Congress, and I mean this both sides of the aisle, both Republicans and Democrats, they believe greatly in value-based payment and moving away from fee-for-service. Most recently, last year, they passed a law called MACRA. It's complicated, but essentially a physician payment system in Medicare, where it doubled down. It did 2 things. One, it said every physician in Medicare is essentially going to be paid at some level on value, but also created incentives for physicians to go in what they called alternative payment models, ACOs, bundles. Well, the only way the government can create alternative payment models is if there's an innovation center there. And you quickly saw when Congress was trying to repeal the Affordable Care Act, well, the Innovation Center is part of the Affordable Care Act, but they took that out. So despite a lot of turmoil, I do think the trend towards value-based payment will continue, with one big caveat that I worry about, which is I worry about the pace. So when we were there, we were trying to do more and more, faster and faster. And I don't know if the current administration has that sense of urgency that we felt.
Yeah, so let's talk about the adoption of some of those models. And when you were, at the helm of Medicare, what were the conversations like to get physicians and providers to enroll in more, Or do you mandate? Do you maintain a voluntary structure that people can sign up to participate in these reimbursement models? I know that we have lots of hospitals and SNFs in the room that are probably really interested in thinking about, are they going to actually have a choice in the future?
Yeah, I think it's been an evolution both in the thinking and the actions on the government side. At the beginning, we very much wanted to capture the energy of people who were true believers and who wanted to be at the vanguard of changing payment, changing care delivery. So we did things like one of the models we launched called the Pioneer ACOs. ACOs are accountable care organizations that manage the care of Medicare beneficiaries. And that was purely voluntary. We said, who wants to be at the lead of this? And one of the advantages of being at the lead was they were at the table with us, helping to design it, telling us what was working, what wasn't working. And we were changing the Pioneer ACO model as it went along. It was interesting. We often got criticized in the press, like, you guys know what you're doing, you have to change the program every couple of months. And we said, well, actually, that's the nature of innovation. You learn, you make changes. But the DC press, that's not what they're used to. So at the beginning, it was very much, let's take advantage of people who want to be at the vanguard. The problem is, you can't just work with people who are at the vanguard in the long run. Everybody needs to move along this continuum. So over time, we were trying to do two things: have models that were lower risk for physicians and hospitals and everybody to get into. But then we actually, about a year ago, maybe a year and a half, proposed our first what we call mandatory model, which was, and that served two purposes. One, we wanted greater participation, but also, and this was a bundled model, payment model. But it also solved a problem, which was we had a lot of participants, but in a lot of different bundled payment models, and we didn't have a big enough number in any one model to do a good evaluation and show that it was working or not working. So one of the things a mandatory model does is, from an evaluation perspective, it increases your N. You get a big enough number so you can figure out, does this thing even work?
Yeah, so you talked a lot about in that kind of question and comment around the government actually iterating several times. And so talk to us a little bit about the government and being a historic kind of regulator and moving into kind of this partner model. And I think that it's very similar to what we're seeing on the front lines happen, where there's many more partnerships spurring up, and maybe you can elaborate on what that is from a government perspective, and then also how that translates down based on the models that you guys have developed.
Yeah, I think that's a really interesting topic, because early on in the Innovation Center we said, well, Medicare can't make these changes alone. Medicare is an important payer, a big payer, but if you're a doctor, a hospital, a skilled nursing facility, you've got many payers, and you want them all sort of rowing in the same direction, if nothing else. So we were constantly trying to figure out how to work with other payers, how to work with providers to make sure, one, they thought what we were doing made sense, but that they were getting a consistent set of incentives. And that took different forms over time. Most recently, we created something called the Learning and Action Network. And this is literally convening where we invited anybody to join. And so national payers joined with us. And it was just a series of meetings saying, here's how Medicare sees the world. Here are the goals we've set on payment and care delivery. Do these make sense to you? Do you agree with them? Should we adjust them? And providers are at the table too. And it's been a really fruitful discussion. But I would tell you, it's not an action that comes naturally to the government to be this open. First of all, there are laws about how you hold meetings and who gets invited, which doesn't lend itself to free-flowing cooperation. So we've struggled, I'm out of the government now. When we were in government, we struggled with it, but we did realize it was important that we couldn't be sitting in Baltimore issuing regulations saying, this is how the world shall be, that it needed to be collaborative, and as you said, it needed to be a learning experience.
Yeah, so how do you see that playing out in the actual communities that are maybe engaged in ACOs, or what are the mechanisms that you guys provided from a policy perspective to actually entice this new point of collaboration and partnership?
Again, I think we're still figuring out what the right way of doing this is. So as I said, we had this national Learning and Action Network. The other thing we did, though, was we gave states a bunch of money and it was a project called State Innovation Models. And we said, a lot
really
of
innovative name there.
It's hard to hire marketing people in the government. They're all out here. And what the state innovation models was trying to do was recognize two things. One, healthcare is more local than national, typically, but also that states, both as a regulator and a payer, are big players in healthcare, but also in some states in particular, the states have a history of being a convener, bringing, whether it's through their governmental authorities or just informally, bringing together people to solve local problems, particularly in public health, but sometimes outside of public health. So we try to provide seed money for states to be conveners and do these things too. And we see a number of projects. I mean, there's some extreme examples. In Maryland, they're moving to global budgets for the whole state. Vermont's kicking that around. But you see more mainstream efforts in other states where Arkansas has, for example, has a statewide primary care medical home model that they've successfully implemented, and now they're trying to layer bundles on top of it. So you do see state-based action as well.
Yeah, and then how do you see some of the models actually getting physicians and social workers and nurse practitioners and the whole kind of community of providers to actually getting people home and keeping them at home and using alternative sites of care to actually deliver care?
Yeah, I don't know if folks will remember or if you were aware, but before the Affordable Care Act passed, there was a lot of debate about Medicare spending. And this is really more true about Medicare than other healthcare spending. But in Medicare, if you looked at how much Medicare spent per beneficiary, community by community across the country, there was enormous variation, spending much more in some communities than other communities. Now, some of that is because Medicare payment methodologies vary by community. But when you drilled down on the data, what really explained most of the variation was how people used post-acute care. So what happened, what was the pathway of a patient when they were discharged from a hospital? And that explained more than half of the variation. So we thought this was a big opportunity. The other thing, you won't be surprised, is those variations had zero correlation with the quality of care patients received. So areas that had very high post-acute care spending didn't have better outcomes. In fact, sometimes, not always, had worse outcomes. It was almost random. Areas with very low post-acute care spending sometimes had great outcomes, sometimes. The spending and the quality just were totally uncorrelated. But we saw anytime in an industry you see variation, it's an opportunity for efficiency. So a lot of the models we tried to launch tried to create incentives for people to think of what's the right way to use post-acute care. And so you don't see the name post-acute care in any of the names of the models, but ACOs are very much looking at post-acute care. Bundles clearly are looking at post-acute care. Even some primary care and medical homes, the more sophisticated ones, are trying to figure out what's the right way to use post-acute care. And when people drill down on that, they do see there are many patients going to high-cost, high-acuity settings that perhaps could be at home, with home care, with other forms of care. So I think you see a lot of that going on. I will say it's much easier to do my job, which is change the payment system, than it is to do your job, which is, all right, now let's change the way care is delivered.
Yeah, so when we were talking and catching up last, you mentioned that your dad has had a recent experience with this, and maybe you could elaborate on what that experience is for you guys as a family and leveraging Medicare's reimbursement strategies to keep people home.
Yeah, so in defense of the Affordable Care Act, which was under siege all the years we were at CMS, we tried to promote successes. So we constantly talked about how Medicare spending was actually slowing, probably because some of the work we were doing, that the quality of care Medicare beneficiaries were receiving seemed to be getting better. So 10 million beneficiaries in ACOs are getting better care than beneficiaries who are in fee-for-service. The incidence of hospital harm is coming down. But every now and then, one of us would have a personal experience to remind us how uncoordinated the healthcare system is. And Kelsey mentioned my father. My father had surgery for something fairly routine, and then had all sorts of problems after surgery and the doctors could never figure out if it was related to the surgery or not. But he had, and this is not a HIPAA violation, I have in writing his permission to talk about this. He was like, why am I signing this? So what happened was, after the surgery, he was at home, and he would have sudden bouts of complete loss of strength in his legs, which was one thing when he was laying in bed, another thing when he was walking across the room. And so in and out of the hospital in like a 12, 13-month period, he was in and out of the hospital 6 or 7 times, sometimes admitted, sometimes not.
I see our hospital folks cringing at the readmission penalty notion.
And terrible communication with the family. His primary care physician was out. Like, I called him, and he's like, yeah, if your dad ever wants to see me, you should make an appointment. And I was like, well, do you know he's been in the hospital? Didn't care, didn't know. And I'm not here to blame anybody, because the first thing you learn is you don't get things don't get better if you run around blaming people. But the system wasn't set up for him to care. So finally, I called a colleague. One of the nice things about working at CMS is you meet a lot of doctors. I called a friend who's a doctor. I said, I think what my dad needs is not all these specialists, but he needs someone to sit down with him for like an hour or two, a geriatrician or someone, and just figure out what the heck's going on here. And my friend put me in touch with a geriatrician from Washington Hospital Center near where my father lives. And it didn't take an hour or two, it took 15 minutes. He looked at my dad's medications and he threw half of them away. Like literally swept them off the counter into the trash can. 10 days later, my father was up and walking. That was 2 years ago. He's never been back to the hospital. I called the physician. I said, can you give me an example of why my father shouldn't be taking these medications? And he said, well, your father was on statins. I said, yeah, statins are good, right? We want people to take their statins. He said, well, your father's 80 at this point, 86 years old. Guidelines say you stop taking statins at 75. And it occurred to me, my father's one of those old men who walks around with his medication list and shows it to everybody, the postman, probably a HIPAA violation, but shows it to everybody, including the people at the ED, including his doctors. So I was like, how many healthcare professionals have looked at that list in the last 2 years or last 12 years and not said, why are you still on statins? So it just drove home. We've made great progress. Everybody's talking, trying to get better, but we've got a long way to go. Yeah, and needless to say, so my father is educated, has Medicare plus supplementary insurance. Like this isn't a story of the two-class system in America where someone poor is getting worse care. So, and again, I'm not here to blame anybody, just that there's plenty of room for improvement, even though we've made great strides in recent years.
Yeah, so let's pivot to improvement. And I know that for folks one of the most refreshing things for me moving from Washington, D.C. after almost a decade out here to the West Coast is that I'm not peppered with the political news every morning here. And so we have a new Secretary of Health and Human Services, Secretary Tom Price, who's a general surgeon by trade from Georgia. And I know that you've heard him speak several times, and there is vast room for improvement. And I think that here in this room, at Honor, we always are constantly striving to seek that improvement on the front lines. But from a DC perspective, from a Beltway perspective, what are they going to do to facilitate, or what are you hearing that's going to happen from Tom Price's perspective?
Well, it's interesting because Secretary Price is obviously in a very powerful position. He's the head of Department of Health and Human Services, which has the FDA, CMS. It's got over $1 trillion of spending under it, enormous regulatory authorities. And yet he is very much out of step with many policymakers in Washington, D.C. about what needs to happen in healthcare. He's what you would call a doctor's doctor. He believes the biggest problem with American medicine are people like Shawn Cavanaugh and private health insurance companies telling doctors what to do, bundles, but all sorts of regulatory things. And what we really need to do is get the government, get private payers off the doctor's back. He's not completely wrong. I have some sympathy. The practice of medicine has become incredibly regulatory. There are a lot of paperwork and other burdens. And I do think that attitude can be channeled in a productive way. It would be great if we could free up doctors to spend more time with patients. I do think it's out of step to think that alone will solve the problems of American medicine. I do think we need new payment models. I do think we need the collaborations that you've seen among providers. So everybody's waiting around in D.C. to see how does this play out. He believes one set of things. Congress, Democrats and Republicans, believe something completely different, which is we do need these payment models. It's not clear what the White House thinks. As I said at the beginning, we're all waiting for this Affordable Care Act repeal stuff to play out and resolve itself one way or the other, so then we can move on and figure out, well, what do they actually believe in? What are they trying to accomplish?
Yeah, so if I'm a frontline provider sitting here in this room today and I'm in an ACO or I have a bundled payment arrangement, should I be scared or what should I be thinking?
No, I don't think you should be scared at all. I think you should be doing the best you can and seeing what you can learn from it, because I think we all have a lot to learn. What I think the question mark you need to worry about is, if you like the bundle or if you think that's the right direction to go, will Medicare, will private payers keep moving quickly enough in that direction? I very much worry about particularly hospitals, but doctors as well, having one foot in each world. So one foot in the value-based world where they're trying to change the way they practice, but a significant part of their business is still fee-for-service, where to thrive you need to do something very different, which is churn patients, churn procedures. And I think we are betwixt and between at this point, and the longer we're in that middle ground, the more confusing it will be for doctors and hospitals, that I would like to see us accelerate to the value-based world. And so that's one of the big questions about this administration. Will they keep up the pace of change?
Yeah. So on the pace of change, what was the pace of change in the topics that when you, not during your time at CMMI, but when you were head of Medicare, what were the top items discussed to change reimbursement strategies or to engage beneficiaries or to really drive down Medicare utilization inappropriately?
That's an excellent question. I mean, we had everything you see out there now was ideas that have been around for a while. So bundles, medical homes, ACOs, and we sort of gotten that all out. And now we're going to iterate on them and make improvements and hopefully learn from them. But we were really at a juncture where we said, what else? And there were plenty of people saying, nothing else. Like,
just stop. Let us breathe. Yeah.
Like, how many models do you need? Let's just expand and improve the existing ones. And others said, no, the nature of innovation is you keep trying new ideas. And I really think that's where we were, and we were waiting, to see what the new Clinton administration wanted us to do. And obviously that didn't happen. So it will be interesting to figure out what happens next. I do think you'll see the growth. So this is a bit of an untold story, but so ACOs, everybody's been hearing, and sometimes you hear kind of good news, sometimes you hear bad news. The truth is the ACO movement is growing like crazy. So there's 40 million Medicare beneficiaries who are in fee-for-service, so which means they're eligible to be in an ACO potentially. 5 years ago, there was no such thing as an ACO. Today, 10 million of them are in ACOs. And every year that number has been growing dramatically. So I think it's an interesting and untold story.
Yeah, so you mentioned in the hopes of a Clinton administration. So tell us about your last day at CMS and how that came to a halt.
So when Kelsey and I met, I was hired originally as just a regular civil servant. So I was a GS, whatever.
The GS scale is how you're paid in the federal government. So like you're ranked, like people walk around just being like, are you a GS 9, 10, 11, 12, 13?
Very much a status.
Yeah.
It's only within government would your GS level be a status.
Mind you, your government rates are clearly not very high and quite depressing if you were to do it on an hourly basis.
Yeah. So, but after that, I became what's called senior executive service, which is this really grandiose title that came with like $3,000 more money. And then when I was moved to become the head of Medicare, I became a political appointee. So the difference being the civil servants are the permanent government. They stay regardless of the administration. The political appointees, as the head of Medicare, meant I had to leave at the end of the administration. So people keep asking me, when did you leave? And I was like, I can tell you to the minute when I left, because it's in the US Constitution. I left the moment Donald Trump took his oath of office, I was out of work. So that was January 20th at 12 o'clock noon, almost precisely. My last day of work was interesting in that I couldn't get into the building because it was right across, the HHS building is right across the street from the Capitol where the president was being sworn in. And I'd already turned in my badge, so I couldn't get in through the security. So my last day of work was actually half a day sitting at home.
A little anticlimactic.
Yeah. But no one was wondering, where is Shawn?
Yeah. So where is Shawn now, though? So what are you doing in regards to work, and what interests you these days? You had a really fantastic opportunity to have a purview that most people would never even dream of getting, and how are you kind of translating that perspective into what you hope to do next?
One of the great things about the people we worked with was they knew that there was a lot of work to be done to improve American medicine. Government can be part of the solution, isn't the entire solution. And a number of these folks have gone on, like you, gone on to really interesting careers. Sachin Jain, another colleague of ours now, the CEO of CareMore, doing really interesting things with elderly people with multiple chronic diseases. He just launched a campaign about loneliness among the elderly, which is pretty cool. Rick Gilfillan, who hired both of us, is the head of Trinity Health, which is like an 80 or 90 hospital system, and he's starting ACOs around the country.
I think he's mandating them.
Yeah, I think he really appreciated going to the private sector where, like, when he decided something, it happened, rather than then he had to talk to HHS and OMB. But so I'm trying to figure out, like, what is my role in trying to continue this work, but from outside of government? I have the unique limitation of my wife works in Washington, D.C., so I live in Washington, D.C. So we're like, all of us are like, this work is happening out in the, throughout the country, but I can't go throughout the country. Yeah. I live in Washington, D.C., and not a lot of it's happening in Washington, D.C.
Yeah, so what are you interested in? Based on kind of what you saw in Medicare, where do you think the opportunities lie in general in the industry, and then for you specifically?
What I've been telling folks, and I've been doing some consulting, is anybody who's trying to improve care for beneficiaries, whether it's by making it more efficient, by improving the patient experience, or by improving the quality and the outcomes, that's work I'm interested in. And the exciting thing is there's tons of it. And it's in all things. Like I would never have guessed you would end up where Honor is, which is technically, it's not even a Medicare benefit, right. But it's clearly part of the continuum. It's clearly, and we have another colleague that I've been doing some work for. He's at a group called Health Leads. So Rocco Perla is president of Health Leads. They don't do anything medical. They're trying to take patients as they get discharged from hospitals and saying, all right, you got your medications and you got this, but do you need Meals on Wheels? Do you need better housing? And they're doing sort of what we call social prescriptions. They're writing scripts for the social needs of patients. So I've started working with Rocco. I've been doing some of that. Again, no Medicare reimbursement for that whatsoever. He's not trying to get Medicare reimbursement, but if he does his job well, Medicare patients benefit.
Yeah, so you bring up Medicare reimbursement, which is obviously something that we talk a lot about at Honor. Obviously, the primary market of home care is private pay, 70% private pay. The other 30% is primarily Medicaid or long-term care insurance. And so we kind of, sit on the outside, which feels really good some days, outside of the regulatory environment of the burden of working with Medicare on a day-to-day basis to get claims paid and such. But it can also be a hindrance because at the point of discharge, people aren't even asking, do you have home care, or what's next, or how are you going to get up your 6 steps at your front door, and do you have fresh food in the refrigerator, and who's going to make sure that the rugs are moved so that your walker can, move about your home smooth and safely. And so it's something that we think about, and we've had the good fortune of getting some waivers from CMS in some of these alternative payment model contexts. What I'd be interested, Shawn, is, what do you think Honor should be doing to also reach the market and to create more collaboration opportunities with the provider community?
Yeah, it's interesting as you think about it. The type of work you're doing and the type of work anybody's doing around the healthcare system can often have more impact on the health status of a patient. But it's a space that Medicare has never been comfortable with, which is interesting because we came from the Center for Medicare and Medicaid Innovation. Medicaid has been comfortable with it. Like through state-based waivers, they've been involved in housing and lots of things, home and community-based services that Medicare has just never been in. So one, I think for policymakers like I used to be and the ones who are there now, one of the challenges is how do you make Medicare embrace this more holistic approach to care without blowing open the trust fund, right? How do you do it in an era of constrained resources? As far as what Honor should be doing, I'm really impressed with what you've been doing. I think you're a good example, though. The fact that you just haven't taken off even faster, as much as you've grown, means the government, and as I said this at the beginning, our job was to create a business case and a financial and regulatory environment for providers to do the right thing. And I think we need to do more and more of that and accelerate the pace. And I think if Medicare did better about that, really through all of its tools, created an imperative for physicians to improve the whole experience of care for patients, I think Honor and people who are in similar spaces, you're business would take off even more than it has.
Yeah, you kind of hit on something that I want to touch on here, which is what is the future of the Medicare Trust Fund? What's the solvency of it? Is it going to be around when I turn 65 and when all of our colleagues turn 65?
Well, we all have our favorite scare statistic. You use the 10,000 a day. The scare statistic I use is if you look at the Medicare, so Medicare has actuaries and they publish a trustees report about the status of the trust fund every year. And last year they said from 2015 to 2025, so it's a 10-year period that we're already 2 years into, total Medicare spending would go from $650 billion a year, a big amount of money, and would double to $1.3 trillion. Even in Washington, D.C., $1.3 trillion is a ton of money. And so it's just sort of mind-boggling that we could spend that much on healthcare. Having said that, so first of all, you might see other numbers out there. That's total spending. That's all the money out the door. There's premiums and other things that offset some of that. But currently, the trust fund is due to the hospital trust fund is due to go bankrupt in 2028. There's lots of ways. What I tell everybody, though, is don't panic. The way Medicare is funded is not written in the Constitution. There's lots of things we can do to fix that. Unfortunately, in repealing the ACA, Congress is actually moving in the wrong direction. There was one tax in the ACA that was helping to shore up the trust fund. So if they pass the repeal of the ACA, the exhaustion of the trust fund will actually come closer, which I think is crazy. But it shows, even though I think it's the wrong way to learn a lesson, it shows these are decisions. Like the trust fund isn't going to go broke because the laws of nature require it to go broke. It's going to go broke because of decisions we make about whether to adequately fund it or not.
So then we're sitting here in Concord, California. What should we be doing, or what could we be doing so that Medicare does exist when I turn 65?
Exactly what you've been doing. So when you think of the trust fund or you think of Medicare, and this is what I've always said, there's lots of ways to improve the financial status of the Medicare program. One is you could raise taxes and put more money in. Incredibly popular, right? We're about to repeal a tax. You could cut benefits. Nobody wants to cut benefits to Medicare beneficiaries. The only thing Congress has done in recent years is add benefits. You could cut payments to doctors and hospitals. We've got a long and successful history doing that, but that's sort of a limited, there's only so far you can go there before you start worrying about whether people will see Medicare patients. And Medicare payments relative to commercial payments are pretty low right now, so there's limits to that. The other, and I think this is why you see bipartisan support, is you could move to value, meaning you could get greater efficiency out of the current spending that we already have. And I think that's why you see bipartisan support, is people are hoping and praying that as you improve the operations of the healthcare system, it will generate savings. And that rather than having these awful choices, you have a good choice where beneficiaries get better care at lower cost. I personally don't believe, I think that work is the most essential. I think those of you who are doing it are doing the right thing and need just keep doing it and doing it better. I don't believe it alone will solve problems. I think you'll need new revenues and other strategy. But that has to be part of it, because we all know of waste in the system, not just fraud, but just waste, inefficiency in the system. And we know the system can produce better results too.
So I want to pivot kind of completely off of the nerd status conversation of like CBO reports and, annual scoring and the solvency of Medicare Trust Fund. So what do you do when you're not reading these reports, and like, who are you outside of a policy wonk on the Beltway?
I was telling a friend, I'm a stay-at-home dad for a daughter who doesn't want me to be at home. She keeps coming in. It's like, it's weird that you're here, Dad. So I do consulting, but I work out of the house, much to her dismay. She's 14, which is exactly when she wants the house to herself. And I think that's enough personal stuff. Yeah.
So this day is ultimately for all of you, and so I want to turn to the floor, and if you guys have any questions for Shawn, and engage with him about what he's been up to in the future of what Medicare means to you as a provider or community partner.
The other thing I would say is, as the head of Medicare, a huge part of my job was having doctors and hospitals yell at me about something. I kind of miss it, so if you want to do that, please.
A nice verbal abuse session here coming on. Yeah, Christine.
Thank you. That was great insight into the policy. I was curious what role you think telehealth will play in the future and how Medicare will support the reimbursement of telehealth.
So the question, just to make sure everyone heard, is, what's the future of telehealth reimbursement and what should we be preparing for?
So telehealth is sort of the classic case of Medicare being sort of caught in a weird situation. On the one hand, I think we would all like to see more telehealth. So currently Medicare will cover telehealth, meaning a patient visiting a doctor by real-time video, but with all sorts of restrictions. The patient has to get to a healthcare setting, they have to be in a rural or underserved area, all sorts of restrictions, which means it's not used nearly as much as it probably could be. And yet Congress has never expanded, and that's written in statute, like all these requirements. Congress has never expanded it because they're fearful in a fee-for-service environment, rather than lead to more better care, you'll just see people churning patients through these telehealth visits, and it'll just run up expenses. People in the delivery system tell me, no, this will replace making people travel long distances, or it just allows us to see more patients. It'll make the program more efficient. I do think it someday will break this log jam. When we were at the Innovation Center, what we did, we had some authority to waive some of the statutory requirements. And we did it in limited ways in some of the bundles models and some of the ACO models, largely with pretty good results without a huge run-up in expenses. It didn't lead to tons more telehealth. But I think we need to solve this problem because telehealth is pretty limited use of technology. There's tons more we can do in technology. To invoke my father again, before he's got this great new geriatrician. But before that, he's like, I'd give my life if I could get my doctor on the phone for 10 minutes rather than me having to schlep across town, sit in the waiting room, tell him what my problem is. And I know it's just a phone call, but the doctor won't do it because he's seeing patients and he won't get paid for this. Phone calls, emails, all sorts of expanded communication. My dermatologist, I have, basal cell things. I promise no more personal stuff. Whoa. But she's like, with some of my patients, they can take a picture with their iPhone and send it to me, and I can tell them whether they need to come in or not. But most insurance, Medicare won't take that. But she said it's great. I can scroll through it. So I think telehealth is sort of, we're fighting this 30-year-old battle, and it's keeping us from getting to much more modern and more interesting stuff.
Molly, you had a question?
It kind of along the same line. We talked a lot of a focus on hospital reimbursement and post-acute care, but I'm interested in the innovations conversations if there was ever, or what is happening around quality and incentivizing people on preventative care. Coming from the hospital environment, at that post-acute point, oftentimes we're too late in a lot of the conditions of health. So is there work that's being done to look at how people are trying to prevent even coming to the hospital or utilizing those post-acute resources?
Yeah, that's an excellent question. And I think we thought about it in two ways. One is, and I hate to keep leaning on the crutch of ACOs, but if a mature ACO, if they feel like, all right, these beneficiaries are going to be with us for 10 years, and they've taken care of post-acute, they would begin to think about prevention, right? Because they would be incentivized to generate shared savings. But I haven't seen a lot of it. To be frank, I don't want to lie. But we thought, if we put providers at risk over the long term for the total cost of care, they would spill over into preventive and social determinants of health. So there was that. And then we also, though, tried to find out, were there specific preventive type things we could get into that more directly rather than through ACOs. And one that was surprisingly very effective, I don't know if you've heard of the diabetes prevention program. So the CDC has long recognized there are certain programs called diabetes prevention programs where they can target people who are pre-diabetic, so very clearly at risk of becoming diabetic. And there's a regimen of exercise and counseling and stuff that actually has a huge body of evidence around it to show that they slow the progression of diabetes or prevent people converting to diabetes. we, at the Innovation Center, we funded the YMCA, which was a big diabetes prevention program. They did a big national test of it. And it's the first thing, it's the first preventive benefit out of the Innovation Center that in 2018, we will now cover diabetes prevention for all Medicare beneficiaries using the Innovation Center authority. And diabetes is a huge problem, not nationally, but also in the Medicare population. It's been enormously difficult for Medicare to do this because people who provide diabetes prevention are places like YMCAs, and Medicare's not used to paying YMCAs. We don't know how to enroll them. We don't know how to pay them. They don't know how to bill us. So the reason it's rolling out in 2018 is and maybe even later, is we all have to figure out how does this even work. But it was nice. It's a preventive benefit, has a evidence base. But it shows Medicare is really hard and doesn't come easily to Medicare to move in this direction. But there is interest.
So on the interest of, starting to extend benefits beyond what we see in Medicare Part A and B and C and D, a lot of these models have left out Part D, the drug part of Medicare. What's going on there? We know that, you gave the example of swiping half of your dad's drugs away. Well, if there is a provider at risk financially for prescribing those, one would argue maybe there wouldn't be so much overprescription or overutilization of drugs in different settings. And at Honor, we know that 100% of our clients are on medication. It's a big issue inside the home, inside the clinical setting. What were you guys thinking along those lines?
Yeah, Part D has not gotten a lot of attention. I think Part D, just for those of you who don't know, it's the prescription drug benefit in Medicare created 10, 11 years ago. Congress spends all of its time patting themselves on their back for creating such a terrific program, and it is a great program. But it has serious problems. It's the fastest growing part of the Medicare program. Drug prices are growing like crazy. Unlike Medicare Advantage Part C, where we hire HMOs and they take full risk for treating patients, the Part D plans are actually at risk for very little of the spending. So if you think of $140 per member per month of drug spending in Part D, the plan is actually bidding on about $30 of that. The rest of it's just the federal government's paying right out of pocket. So it's not a well-managed benefit. And then as you point out, in these new models, which are ACOs and bundles, we have not included Part D spending so that physicians don't feel like that's part of their strategy. And the reason has been it's very complex the way Part D was structured. It's so much different than the rest of the Medicare program, which is fee-for-service and lends itself to this sort of approach. And we spent a lot of time thinking about it. I'm actually working with some professors at Johns Hopkins now trying to write a paper suggesting how it could be included. And we haven't come up with the solution. So we actually backed up and are writing a different paper about why it's important that it be included. And we're just sort of stalling till we come up with the idea of how it can be included. But at Part D, I think, is going to be, you've already heard nationally a lot of talk about drug prices, but you don't hear about it specifically about Part D. Part D has all the drug pricing problems the rest of the country has, and then some problems unique to Part D.
Yeah, well, if you need some fast facts about medication adherence, we know that all of our care pros are helping remind our clients every day to take their medication on time and to stay adherent to that. But like you said, the overdosing is also an issue. And I was in a family's home last month, and you walk in and there's like the M&M bowl, right, of medication, and it's like, well, let's talk about medication. Do you need a care pro to help you remind you to take medication? And they're like, well, I just kind of pick one out, and whatever day I feel like it. And this is real. And so I think that we really have a responsibility to alter the way that the medication environment is reimbursed and the risk structure of that. What other questions do folks have? Yeah.
I just had one. I'm interested. My company makes actually a revolutionary new product that allows a home that's not accessible to become accessible. And I just had a question.
I'm sorry, what that's not accessible?
We make products that make, for example, take a bathroom that's not accessible.
Oh.
Simple product makes it accessible. So it provides a senior viable alternative to nursing home placement, for example. Our products plus part-time giver provides a viable option nursing home placement. I guess my question to you, the potential is huge cost savings to Medicare. My question to you is, in general, how does a person or company go about presenting a case study or model to Medicare to consider funding a product? Right now, it's not a funded product.
Yeah, so there's two ways. The first thing I would send you to is if you Google, I always get the title wrong. The CMS has what's called an Innovator's Guide to Medicare. And
It's kind of an oxymoron.
Yeah. Yeah. I was about to say, it's not an easy read. But it talks about coverage coding and payment, what you go through. So that's the traditional statutory route. And the other route is through the Innovation Center, which has unique authorities. And if you're in Washington, or actually Baltimore, you could reach out to them. They have a group in the Innovation Center called the Policy and Programs Group, which is where I started my time at CMS, where part of what they do is people just come through and talk about what they're doing and why Medicare should be interested. And they give advice. They either say, sorry, we're not going to, well, they hardly ever say, they're very nice.
Yeah.
But you know, they hear 1,000 ideas for every 2 or 3 that they pick up on. But if you have time, it'd be worth telling them what you're up to.
I think the second piece of that answer is that, you know, having quantifiable outcomes related to what it is showing and the cost savings that could be accrued over time are also important. Because if you think about, you know, CMS is really interested in cost savings and keeping people at home and other sites of care. And so quantifying that really succinctly where they can actually grapple with it in, you know, 20-minute conversation, because you'll probably only get 30 minutes, is really important. Yeah.
So right now I am working on a business case study to prove that.
Yeah.
How about the quality of life improvements? Is that something they consider as well, or is it?
Yeah, so I think it's good to, the statute that created the Innovation Center set up how the Innovation Center is supposed to think of things. They're supposed to be interested in 2 types of things. Things that improve quality of care without increasing spending, or things that reduce spending without decreasing quality of care. So as long as you can fall into one of those buckets, it's consistent with their mission.
Great. We had a question up here.
It's a follow-on to his question. I'm part of a nonprofit called The Villages. It's part of a nationwide network that helps seniors stay in their home using volunteers. Talk about cost containment. Are you guys looking at utilizing those types of programs across the U.S. in order to keep costs down?
My father's a member of Capitol Hill Village in Washington, D.C. So thank you for that. Not directly. And again, this is about, I think someone else brought it up too, not a traditional Medicare provider. There's thinking about how do you broadly capture these non-medical resources, or how do you maximize them. This group, Health Leads, I know works closely with some villages. So I wouldn't say you should expect to see a model out of the Innovation Center immediately, but it is part of a larger school of thought of what is the relationship between the medical system and the non-medical system, with a full knowledge that things you're doing have direct impact on medical spending. But I wouldn't expect to see anything in the near term directly working with villages.
Yeah, I think when we were at our time there in the government, you know, we always called those the social determinants of health, right, is the jargon that we used. And we were constantly considering them. And it's fun to actually be at Honor now where we're impacting those and we're finding new little ways to weave the needle to find alternative payers for that as well.
The one thing I would say, I'm sorry, it just occurred to me, there was one model out of the Innovation Center called Accountable Health Communities, which was trying to support community-based approaches. So you might want to go to the Innovation Center website and just read more about accountable health communities. I think it was targeted more around cardiac health, and using, but it could be a springboard for other future community-based approaches.
We had a question. Yep.
Yeah. So kind of following up on what I mentioned about value-based care and quality outcomes. So kind of in health technology, as things kind of grow, it's generating a lot of different types of data. So I'm kind of wondering, you know, with all this data going on, whether you're getting data from Fitbits or whether you're getting more data on medication adherence, where do you see kind of what are the most important data that technology should be kind of looking at to demonstrate, you know, improved quality of life? Should be looking at, reductions in social isolation, reduction in depression, being more interested in that, even cost saving, impact on patient knowledge, or what's your take on that?
Yeah, again, I take you back to the statute that created the Innovation Center, where two things we were supposed to balance. One is cost savings, and Medicare in that context is very clearly talking about Medicare or Medicaid cost savings. So the government can measure that pretty easily. Where it gets a little trickier is it says quality of care, which for any person could mean different things, right? Some is patient satisfaction, some is clinical outcomes, some is clinical process measures. And CMS has had different set of quality measures for every model, but I think that is an area where the public can provide a lot more feedback to the government about these are the things that matter to patients, and here's how you ought to think about quality. And there's a lot of ways to do that. But having said that, the government is constrained in its ability to collect a lot of these data on quality. So, claims-based measures are easy, but once you're moving to more clinical measures, the government doesn't typically collect a lot of that data, and it becomes more of a challenge, even though that might be more relevant. The thing we've all held great hope for was as electronic medical records became more ubiquitous and more interoperable, it could be seamless collection of these data, which wouldn't burden the physician, would create huge data repositories, but that hasn't been the world we've seen develop yet.
Yeah, I think on the note of EMRs, it's interesting. Honors oftentimes, on the receiving end of a family and a client, and whether it's coming from a SNF or a hospital or maybe working with them in the SNF and providing 24/7 care, we've oftentimes gone back to our partners and said, well, how can we be part of your EMR? And it's get on the waiting list, for several years, and maybe we can have a redesign at some point someday. So I think it's been a challenge universally across not only for the acute settings, but also to increase the coordination of care across those sites. So we have time for one more question. I saw a hand up back here. Yeah.
Just a clarification. You mentioned earlier that the Innovation Center is not part of the repeal. Is that right? I just want to make sure I understood that. And what do you think of the future of the Innovation Center?
Yeah, the bill that the House of Representatives passed and that the Senate is or isn't considering, depending on which day you read the paper, did not include anything that would affect the Innovation Center. And the Innovation Center, just so you know, it was created in the Affordable Care Act, and interestingly, the Affordable Care Act gave it 10 years of funding, and the money renews itself. So in 2020, another 10 years of funding automatically occurs. So not only didn't they touch it, but it is funded in perpetuity without Congress having to take any action. So it seems pretty safe for now.
I think it seems safe, and in part, one of my experiences after leaving the federal government, I then went and worked for one of the largest Republican businessmen in Washington, D.C., and he was creating businesses to convene bundled payment hospitals and such. And so I think there truly is universal support, in part because of the business that it can generate into the private sector and actually leverage that. Well, Shawn, any last words of wisdom for us as we continue the hard fight on the front lines with getting people home, keeping them home, and trying to find reimbursement mechanisms to help us achieve those good things?
No, just keep up the good work. One of the things about working at CMS is, as much as you believe in these programs, and I have always been a big believer in Medicare and Medicaid, once you come to the agency, it's sort of in your bones for life. So whenever I see anybody doing work that's trying to improve the care that beneficiaries receive, I think it's the most important work we can all do, and I really appreciate what you're doing, because the government can help, but the solutions really are going to be coming from you.
Well, please join me in thanking Shawn for traveling all the way across the West Coast